Clinical decision making. This week, and in outlining what we're going to talk about, I'll be introducing concepts of clinical decision making, a form of thinking or perspective called the Gowans perspective, providing examples of clinical decision making, and working our way through a complete self-directed learning exercise. Creating a context and expectations management is one of the major aspects of your clinical interaction with your patient. The aim is to achieve patient satisfaction, but how do you measure this? Is what the patient requests always what is required? And given that all conditions may not be curable, how do we know when we've succeeded in our outcome? In fact, how do we know whether or not we've met expectations? And in terms of a clinical perspective, meeting the expectations of your patient means matching those expectations with the clinical, physiological reality. Part of that process is you as a practitioner managing those expectations. It's important to identify the podiatric diagnosis or focus and ensure, as we've spoken the last couple of weeks, that you discuss what it is as a podiatrist that you aim to achieve, that you can assist with, and in certain circumstances can, if I can use that term, cure. The importance of assessment. A thorough assessment begins with a thorough history. We've discussed the concept of PQRST as an aid to data gathering. Physical assessment then follows the history, but physical assessment will often be based on the thoroughness of your history taking. A thorough medical history will allow you to focus on particular systems or landmarks. Assessments may be localized, such as with an ankle joint, or systemic, such as with the vascular system. And assessment may also involve the need for other tests, such as X-rays to assist in decision making. Overall, the importance of assessment lies in the fact that this allows for the clinical decisions that need to be made. Clinical decision making can be viewed as a chain. Often in order, it is important to determine when to decide, what needs to be decided upon, and the information that you've used in order to make these decisions has to be as thorough and complete as possible. Looking at this jigsaw puzzle, you can see that there are many pieces to it. Signs, symptoms, history, examination, and so on. All of these pieces join together to build an overall picture. Any one of these pieces that is missing has the potential to impact on your clinical decision making and therefore your outcomes. You see again all of the blocks that are being considered: demographic, medical, social history, podiatric history, the results of assessments, lifestyle and activity, medications, and in the middle is a big question mark. In other words, what do all these matters that you've considered and all this information that you've gathered, what does it come together? What does it produce? And how do you use it? Well, this is the hallmark of what we do in terms of our clinical rationale. Typically, all of these come together to form a diagnosis. Followed, in order to reach your stated outcomes, you need what we call treatment planning. And ultimately, patient satisfaction. For all of these to align, though, patient satisfaction has to align with the reality of what you can and cannot do, the reality of the condition or the problem being treated, and the expectations of the patient. Remember that you are acting as a health professional. You are engaging in critical thinking and then clinical decision making. This will seem strange at first, but will become second nature with experience. How can we consider this process in order to describe what is happening? And can this process be learned? Well, there are two ways perhaps of considering how to go about determining the clues, which thought process to put in place in order to use all of the bits and pieces you've garnered through the medical history, and how to come up with a final decision. The two parallel courses may be searching for clues and the generation and selection of hypotheses. And we'll work through these. Typically, we'll work through them in the aim of indicating that the assessment and clinical decision-making process is subject to a lot of influences. You need to be able to turn your mind to the possibility of many things occurring during your consultation. Multiple signs, multiple symptoms, or no signs and no symptoms at all. It may well be an internal physiological concern that is neither felt nor can be cited. Typically, however, you will need to make a decision about what to do next. You can search for clues in the following: the patient history, the physical examination, the laboratory examination, the special anatomic and physiological tests. A typical example: searching for clues in patient history. A patient may present with a history of conditions such as diabetes. They may present to you with a range of symptoms that may be related to complications concerning diabetes. Whilst you're running through your systems approach, for example, trying to determine whether or not they've had a neurological injury, whether or not they've stressed a nerve or injured a particular area, you have a look at their medical history and notice that they have diabetes. You notice that the diabetes has been diagnosed over a decade and a half ago, for example, and that in fact, over that period of time, the blood glucose control has been quite poor. Searching for clues within the patient history, you can start to consider whether or not these neurological changes have or are part of not one isolated traumatic event or injury, but as a result of neurological changes related to diabetes. Looking at physical examination, tests of joints, range of motion of joints, positioning of joints, for example, can assist in determining what is occurring. Laboratory examinations can assist in markers. Are certain markers in the body high, low? Are they indicating anything, such as, for example, uric acid levels, which would be a clue with respect to the presence of something like gout? And the special anatomic and physiological or psychological tests can relate to the muscle testing, the questioning of a patient regarding their symptoms, and the quality of symptoms. The examiner collates information from clues, considers lists of disorders or syndromes that have the clue in common. You then develop an imaginary chalkboard with a list of potential hypotheses, and then you measure clues and tests and symptoms against this list. The generation of more information may include new entry on the list or exclude others. An example: tinea pedis, psoriasis, contact dermatitis, and number 4, is there another condition that I can consider with respect to a patient? All these 3 defined conditions and the 4th unknown condition could relate to a particular presentation before you. Let's consider how we'd work through this. An example: a 32-year-old male. He's a factory worker complaining of itching and scaling of both feet. The symptoms include scaling of feet, itching of skin, the forming of small blisters. The picture indicates the blisters along the lateral aspect of the foot and the dorsolateral aspect, I guess, of the foot. Medially as well, we have the presentation. You examine the patient for signs. The physical examination of the skin indicates extensive erythema, multiple vesicles coalescing into bullae. extending from the medial longitudinal arch to the dorsum. There's evidence of serous exudate. The skin appears hyperhidrotic. It's symmetrical in nature, and there are no skin lesions elsewhere on the body. You develop a set of hypotheses. Could it be tinea? Could it be psoriasis? Could it be contact dermatitis? This is the metaphorical chalkboard that we talked a moment ago about. And you start to test these hypotheses. Does this look like tinea? Does it look like psoriasis? Does it look like contact dermatitis? Coupled with, does it look like, you would need to know what tinea, psoriasis and contact dermatitis do look like. You would need to know their clinical presentations, their particular patterns of symptoms, their triggers, their onset, and so on. Moving forward. You consider documenting further history. There's no family history of psoriasis. There are no other skin rashes. The patient has always had sweaty skin. The boots are new and they're from work, and he wears them all day. You consider some laboratory tests, possible patch testing to determine if there are any allergies. You also consider that other tests are not needed at this stage. Based on all of this, you need to come to a final decision regarding diagnosis. The results of patch testing, the clues from the history, the signs and the symptoms, the diagnosis is contact dermatitis. As you can see by this diagram here, there are many blocks that are in the air at any one time. But you need to consider what aspects of every part of your clinical reasoning come together to form that final decision. Another example, a 42-year-old male complaining of change in colour to the nail plate. There's no pain. The changes have been present for 6 months. They're gradually getting worse and no other nails are affected. You would think to yourself, perhaps, how many disorders do I know that present in this way? The list of hypotheses may include onychomycosis, onycholysis, and leukonychia. Then you would consider, how can I examine for each of these? What are the signs and symptoms of each of these? Is any other skin or nail affected? Are there enough features of any nail pathology to make a provisional diagnosis? Do I need to undertake further tests? Based on the results of all of these questions, you would then move to the next phase. In this case, you observe discoloration, which is white and brown. It extends from the lateral nail fold. The nail is beginning to crumble or be friable. The nail is separated from the nail bed, and the nail is becoming corksick. You consider onycholysis does not have these features. Leukonychia does not have these features. Onychomycosis does have these features. Perhaps you consider you could undertake further lab tests to confirm. In summary, consider that clinical decision-making is a skill that develops over time. It's a skill that needs to be practiced, a skill that's based in rationale, a skill upon which assessment play a major role, and the impact of your clinical decision-making has to be married to the expectations of the patient. It will seem strange at first, but will soon become second nature. Experienced clinicians make decisions all throughout the patient consultation and management phase, and indeed, with time, this will be the same of your experiences.